Okay, once again, pleasant good morning. Welcome to this CPD number 16. Today we'll be discussing about thoracic trauma. My name is Jaynal Canaria. Okay, welcoming you all. So first and foremost, as a presenter, I just want to present that I don't have any actual or potential conflict of interest in relation to this presentation. So what are the learning objectives? Thoracic trauma is a big topic. So that's why we will be limiting our discussion on the following learning objectives. We will have some small or brief discussion about anatomy of the chest, likewise the pathophysiology of thoracic trauma. We will also describe some major signs and symptoms of thoracic trauma. We will list and describe the life-threatening thoracic injuries that can be identified at the scene. There are so many thoracic injuries. Maybe I would say there are 12 at least in this to put context in terms of the number, but in this presentation, we will only limit the discussion for those thoracic injuries that we can identify and somehow diagnose at the scene. Now, last objective will be indicate the life-saving interventions and management of thoracic trauma. Okay, case scenario. Start with how we start our presentation. So for everybody's information, let's read together the case scenario. I'll read it loud. On or about 8:15 in the evening, you responded to a 35-year-old male patient who sustained a single stab wound to the left anterior chest. This is a real case. You might be wondering, is it residential or community? No, it happened in the industrial area. So single stab wound to the left anterior chest. Can you mute your microphone, please? Okay, after ensuring that the scene safety, initial assessment reveals the following.
Mungkin belum di-download tadi soalnya, jadi langsung join.
Microphone, please. You're interrupting the discussion. Thank you, Mr. Moderator. Can you find out?
Yes, reminding for everyone, please mute your mic because it is interrupting speaker when you are talking. Thank you.
Thank you very much. Thank you very much. So let's move on. Let's continue. So after ensuring that the scene is safe, your initial assessment reveals the following. The level of consciousness, the patient is responding to verbal stimulus. He is awake but restless and anxious. Airway, apparently he's shouting and he's saying, my chest hurts. Breathing, fast and shallow labored breathing. Circulation, rapid and steady central pulse. Cool, pale and diaphoretic skin. And there is some bleeding from the chest wound. That's your initial assessment. So there are 4 questions related to this. We will be answering all these 4 questions. Okay, what is the general impression and priority transfer? What is your diagnosis based on your initial findings? Afterwards, how would you further assess the patient? And number 4, what are your treatment and management at the scene? So my expectation, we will be calling someone to participate and answer this, and they will be sharing their comment or answer to everybody. So first question, what is general impression and priority transfer? I just need a volunteer so I can give a heads up. Perhaps I will assign it to Mr. Anel. I just saw you first one, Mr. Anel Bitog. Later, you will answer later. So number 2 question, what is your diagnosis based on your initial finding? Mr. Mike Bunez, just a heads up so you can answer it at the end. Number 3, how would you further assess the patient? That's the 3rd question. Mr. Boris, just a heads up as well so you can think and focus on the scenario. And lastly, number 4, what are your treatment and management at the scene and en route to the hospital? Mr. Ronaldo Domingo, heads up as well. Please share your thoughts or answer later. Thank you. Let's move on. So thoracic trauma. Thoracic trauma is the number one, or trauma is the number one leading cause of death worldwide. approximately 100,000 of people died in US in every year, each year related to trauma, and approximately 16,000 that occurs from thoracic chest trauma annually. So thoracic trauma, as you can see here on the figure 1, it is a time critical condition. When you say time critical, you need to transfer immediately, you need to identify immediately the injuries of the patient, otherwise the patient will suffer or the patient may die. Another information, 25% of trauma death are related to thoracic trauma, and 50% in multiple trauma, meaning in all multiple trauma, 50% patient is suffering from thoracic trauma. And lastly, definitive treatment is one element to consider in thoracic trauma. We need to identify and we need to know what are the immediate life-saving interventions and what are the definitive treatment for thoracic trauma. Okay. So figure number 2, as you can see on the right side, this one, figure number 2, this is the role of EMS in patient outcome with regard to patient outcome. This model, we call it the conceptual model, explain what is the role of EMS providers in patient's outcome. So as you can see here, if the patient got involved in any injury, the outcome of his care or his condition will be based upon 2 things. Acute care management are divided into 2 parts, pre-hospital and the hospital-based care. So I'm just emphasizing it to you all that we play a big role in terms of patient outcome, as acute care are divided into 2 parts, pre-hospital and hospital-based acute care. Okay, in the pre-hospital, it is expected that we EMS providers provide the best and high quality of care based on our scope of practice. It is also expected from us that we have the knowledge and skills to properly assess and recognize those life-threatening injuries. And at the same time, we need to know how to treat them. Also in EMS, we EMS provider need to know the right time whether this patient is a load and go or a scoop and run patient or a critical patient, because there are some parameters or there are some elements that affect the outcome of the patient, especially in the pre-hospital. Let me just share to you this one. One study conducted or published in the pre-hospital in disaster medicine in October 2020, entitled Pre-Hospital Interval and In-Hospital Trauma Mortality. This is Qatar-based, wherein from 2017 June to May 2018, total population of 1,455 patients, a retrospective data analysis of patient transferred by the Hamad EMS and admitted to Hamad Trauma Center. They have categorized and studied about it, and this is their conclusions. Even though there is no direct correlation or the mortality was independent of the total pre-hospital time, but the second one, longer on-scene time in severely injured patients is a big factor. So you need to know whether this patient is a load and go. You need to know that we need to transfer the patient immediately, especially on those severely injured thoracic patients. Okay. This is just a basic anatomy and anatomy, and we will also describe the pathophysiology. The thoracic cavity is a cylindrical shape and contains the major organ or organs of respiratory, cardiovascular, and gastrointestinal. And the bony part of the thoracic cavity are composed of 12 pairs of ribs, okay, wherein 5 are directly attached to the sternum, the other 5 are, we call it the false rib, and there are 2 floating ribs. Anyway, this is just a basic information. And in each cavity, can everybody mute? Can someone mute your microphone, please? Okay, the thorax is divided into 3 compartments. The right and left pleural cavities that houses the right and left lungs. And the third compartment is the mediastinum, that houses the heart, the trachea, the great vessels. So any injuries within that area are life-threatening because of severe blood loss. So on the figure 4, you will see here, this is just some information. The blue one, the blue color represent the lungs, and there is such thing as parietal pleura or pleural space. This is just a potential space. Later, you will understand what is the role of this parietal pleura or pleural space. And also in between the ribs, there are 2 ribs here. Just for information that the intercostal vessels and nerves are located at the inferior borders of the rib, just below the ribs. So you will understand why, especially when we are going to this, when we are discussing about tension pneumothorax. Let's move on. The trimodal distribution of trauma death. I believe there's one question been asked, right, related to the trimodal distribution of trauma death. And there are 3 deaths related to thoracic trauma: the immediate death, the early death, and the delayed death. So the immediate death, usually it happens at the scene. And what are the causes? Disruption of heart and great vessels. Once again, the causes of immediate death at the scene are related to disruption of heart and great vessels, right? While the early deaths from 0 hour to few hours, airway obstruction, tension pneumothorax, cardiac tamponade, and hemorrhage. And delayed deaths like sepsis or infections that usually occur after 1 week. Let's move on. Another one, next, mechanism of injury. Mechanism of injury of thoracic trauma are divided into 2 parts. It's either blunt or penetrating trauma. Blunt trauma, there are 2 reasons why, or there are 2 elements of blunt trauma. Either direct compression, wherein there's a fracture of solid organs, especially in motor vehicular accident, or same as well with deceleration forces. A good example of deceleration forces is the shearing of the aorta, wherein the ligamentum arteriosum will be sheared and torn, and therefore the aorta will bleed. Next one is the penetrating trauma. It's either direct trauma to the organ and vasculature, usually caused by stab wound, bullet, or knife, and any other physical object that penetrates the skin that cause or creating a temporary or permanent opening. Okay. So pathophysiology of thoracic trauma. So chest trauma are broadly categorized into 2 parts or 2 areas. So you'll see here: massive hemorrhage and decreased oxygenation. So let's discuss about massive hemorrhage. What are the causes of massive hemorrhage? Especially, remember the mediastinum that I mentioned to you. If the heart, the great vessels, and the aorta will be injured or torn, it will bleed out, and it can cause massive hemorrhage. Likewise, the lungs. In each thoracic cavity, each thorax can sustain at least maximum of 3 liters of blood loss. Imagine if 1 lung is equivalent to 3 liters, so there are 2 lungs or pleural space, so a total of 6 liters that you can lose in that organ. What is the total blood volume of an individual or an adult? 6 to 8. Okay, about decreased oxygenation, this is usually caused by ventilatory mismatch. If the pleural cavity or the alveoli or the alveolar capillary interface will be injured, therefore there will be a ventilation mismatch and decreased compromised gas exchange. Eventually, if these 2 things will not be controlled, it will lead to tissue hypoxia, which is the definition of shock, and will lead to death. Let's talk about the tissue hypoxia related to thoracic trauma. I think there's also one question. What is the cause, or what are the causes of tissue hypoxia or shock in related to thoracic trauma? So there are how many? 1, 2, 3, 4, 5. 5 contributing factors or causes. 1, inadequate oxygen delivery. There will be blood loss or hypovolemia, especially in severe hematoma or severe hemorrhage or hemothorax. Number 3, there will be a ventilation perfusion mismatch, wherein there will be injury to the lung parenchyma. And number 4, there will be compromised ventilation and circulation because of the tension pneumothorax. And number 5, there will be a pump failure from myocardial injury and tamponade. So these are the causes of tissue hypoxia in shock. Okay, signs and symptoms. These are the typical signs and symptoms of patients suffering from thoracic trauma or thoracic injury. So I just want to give you some assessment technique. So try to remember the inspection, palpation, auscultation, and percussion. Since we're discussing about trauma, most likely the organs or the body parts that we will be assessing are the head, the neck, and the lungs or the thorax or the chest. Okay, inspection. Let's look at inspection. What can we inspect? We can inspect hemoptysis. We can inspect, observe cyanosis. We can see or inspect distended neck veins. In terms of palpation, what can we palpate on those 3 organs? We can palpate for tracheal deviation. Asymmetrical chest movement, we can see. We can also see chest contusions. We can also inspect open wounds. Subcutaneous emphysema is more on palpation. Okay. And lastly, and next one is the tenderness, instability, and crepitation when you're doing your palpation. And next one is auscultation. You need to auscultate for breath sounds. And if you found an abnormal breath sounds, that's the time you will do percussions. And another one, signs of thoracic trauma is shock. So these are the major signs and symptoms of thoracic trauma. So thoracic injuries, the deadly dozen. There are 12 actually. That's why we call it the deadly dozen. But having said in the beginning, we will only focusing or discussing those thoracic trauma or injuries that can be identified in the initial assessment, or especially in the primary survey, or if I may say in the pre-hospital setting. Some like the airway obstruction, the flail chest, the open pneumothorax, the massive hemothorax, the tension pneumothorax, and the cardiac tamponade. And the rest, it requires some diagnostic tool that can usually be found or be diagnosed in the hospital or in the ongoing exam. But we'll focus on the first 6 because it's a big topic. Thoracic trauma is a big topic. First, thoracic trauma injury is airway obstruction, usually caused by, this is secondary to hypoxia. It's a common cause of preventable death, usually caused by foreign body, tongue aspiration, and always assume cervical spine injury. So just for information about airway obstruction, we have a separate discussion or topic about this, but we're just passing through about airway obstruction. This injury is characterized by paradoxical movement of the chest, where the unstable section of the ribs will suck in when the patient will breathe, and then it will push out when the patient will breathe out. So let me just, there's a quick survey here. Can someone answer this one for me? Quick poll. What is your answer? This injury is characterized by paradoxical movement of the chest. Okay. Let's spend some few seconds about this. 9 already answered. Okay, good. Good. Airway obstruction. What do you suspect? What is the injury? So 36 respondents. Thank you. Majority, 84% says tension pneumothorax. Vice versa, sorry. Flail chest, 83% says flail chest. 14% says tension pneumothorax. And 2% they said airway obstruction. So this is the result. This is for everybody's info. So majority is saying 84%, this is a pleural chest. Thank you very much. That's correct. Let's move on. Let me just present. Okay. So pleural chest. Let's talk about pleural chest. What's the definition of pleural chest? Pleural chest is an injury or when there's a rib fracture, at least in 3 or more adjacent rib fractures in at least 2 places or more, resulting in a segment, as you can see here in the drawing, that is not continuity with the thorax. So that is pleural chest. So look at figure number 10. We call it the pleural chest movement during inhalation and exhalation. Normally, if we breathe in, the air will come through the mouth, go to the trachea. So what will happen if we breathe in? Just on your chair, on your place, breathe in. What will happen to your thorax? What will happen to your chest? It will expand, correct? But on affected part that has a pleural chest, instead of expanding, this part that is injured will suck in, will go down. Then eventually when you expired in a normal pace or in the normal lung, when you expire, the thorax will deflate. But in pleural chest, the injured part will expand or open. Okay. So what are the interventions? What are the management that we can do at the scene? Okay. Positive pressure ventilation. That's one of the treatment of pleural chest. Possible intubation. You need to intubate the patient. Okay. It's a load and go situation. Stabilize pleural segment. One of the rules. We will discuss about pleural segment. And monitor for pulmonary contusion, pneumothorax, and pneumothorax. There's some advanced treatment here. Large pleural chest, you need to intubate the patient and attach it or provide a positive pressure ventilation with PEEP. For some of you may not be familiar with PEEP, we call it PEEP, positive end expiratory pressure. It's a small gadget that attaches to BBM, that maintains the end expiratory pressure to keep the lungs inflated. Small chest, you can do the CPAP, and consider pain analgesia. Okay. Update, bulky dressing versus analgesia. So as you can see here, in the ITLS trauma course, the last time I asked who are the people who attended ITLS course. Majority attended what? How many? 4 years, 5 years back. In the new updates, we just have our update as instructor update. So ITLS will no longer be recommending bulky dressing. However, in replacement to bulky dressing is the administration of analgesia. So, but to put some context into this, considering the scope of practice, considering the local settings that you have in your workplace, we can still put some bandage there, but the thing is we need to administer analgesia if available. So they mentioned that in their study, the bulky dressing doesn't help at all. What the patient's complaining is more on severe pain. So that's why we need to provide analgesia. So just to give you an update, we will start teaching this one in the ITLS course soon. Okay. What is this? Okay. There's a poll here. Perhaps can you guys answer the poll for me? If the chest wound is larger than the opening to trachea, approximately 3 centimeters, the air will preferably go into the pleural space rather than the lungs. True or false? Okay. Once again, if the chest wound is larger than the opening of the trachea, approximately 3 centimeters in adult, or larger than their small finger, little finger. So instead of the air going to your lungs from your mouth to the trachea, going to the lungs, it will rather go to the one which is opening, the one in the open chest. So thank you very much for answering. 98% says correct or true. Okay, 98% says yes, correct. That's correct. Okay, let's move on. So you can see here in the open pneumothorax, I did mention if there is an opening larger than 3 centimeters, larger than the opening of the trachea. So you can see here on the figure, on the first figure, figure 13, letter A, there is a stab wound, chest wound, or gunshot wound. Instead, normally, when the patient breathes in, it will come from the mouth, it goes into the mouth, goes into the trachea, and it will enter the lungs. However, if you have a wound, external wound outside, the air will be going in from that external wound, and it will reach the dead space. So instead of reaching the lungs, it will go to the dead space. So once the air enters the pleural space, the ventilation will be impaired, and hypoxia will result to hypoxia. Okay. This is a treatment for sucking chest wound. What do you call this dressing? What type of dressing is this?
Ay, dressing na to. Yung isa naka-open.
Yes, Mr. Eric, please switch off your microphone or mute your microphone, please. Okay, let's move on. So we call it open pneumothorax, occlusive dressing, where in occlusive dressing, 3-sided, sealed, or otherwise you can use an Asserman chest seal. Occlusive dressing, what do you do here is you will put some transparent dressing and tape it on 3 sides and allow 1 side, so that when the patient will breathe out, it will go out from that platter valve, we call it. But if you have an Asserman chest seal, apply the Asserman chest seal. But update, once again, an update from the ITLS 9th edition, instructor update. Okay, this will be a 9th edition. Improvised seal tape, 3 sides versus 4 sides. In the new update, ITLS will be recommending 4 sides instead of 3 sides. You might be wondering, what is this, the one on the far right? So just a tip, a practical application. If you don't have the 4 seals, you can use an AED DP pads and put it on the sucking chest wound. Right? If you don't have this special ACS, but if you have a defibrillator pads, attach it to the patient. Okay? This is just, we will discuss about the tension pneumothorax. Maybe some of you are asking, what if there will be what if the sucking chest wound and we seal it with 4-sided chest dressing, it may create tension pneumothorax. Yes, but you need to do some decompression. We'll discuss it later. So massive hemothorax. Next one is a massive hemothorax. Okay. Blood in the pleural space. Look at the figure number 18. So if blood enters the pleural space, I did mention in the anatomy that each lungs or each side or the pleural space can hold maximum of 3 liters per lung. So if you have 2 lungs, automatic, you can lose as many as 6 liters of blood. So what is massive Let's discuss first what is hemothorax. Simple definition. Blood in the pleural space is hemothorax. Then what is massive hemothorax then? A massive hemothorax occurs as a result of at least 1,500 or 1.5 liters blood loss into the thoracic cavity. Okay? So that's the definition of massive hemothorax. We will call it that massive hemothorax if the blood loss is more than 1.5 liters. So what are the signs and symptoms? Anxiety and confusion. The neck veins, you might be wondering, why is it flat and distended at the same time? Flat if severe blood loss. It's a sign of hypovolemia. And distended, see, look at figure 18 going back. Just follow my cursor. If this one, right, if one side will be affected and around 3 liters of blood will be lost in the pleural space, it will compress the mediastinal area, the mediastinum. That's why you will have distended neck veins similar to thoracic tension pneumothorax. Okay. So when you do your percussion, what will be the result? Or the breath sounds will be decreased on the affected part. And when you percuss, there will be a dull sound. And patient will manifest signs and symptoms of shock. So that's massive hemothorax. So what are the interventions that we can do at the scene? It's a load and go. The definitive treatment for massive hemothorax is operating room, chest tube, depends upon your scope of practice, but in the EMS, we don't do that. Load and go and treat for shock. Another management that you can do is fluid administration, titrate to peripheral pulse, or I think it was mentioned also in the last topic. It's either we titrate to peripheral pulse or we maintain a systolic blood pressure of 80 to 90 millimole of mercury. This is the concept of permissive hypotension. Permissive hypotension refers to managing trauma patient by restricting the amount of fluid or resuscitation fluid and maintaining blood pressure in a lower normal. So what are the side effects or adverse effects of putting too much fluids, especially this massive hemothorax, which is uncontrollable bleeding? So if you put too much fluids big amount of fluid, what will happen? It will increase hydrostatic pressure. It will increase blood pressure, hydrostatic pressure in the injured blood vessels. Therefore, it can dislodge the hemostatic blood clots and will also cause delusional coagulopathy and can result in hypothermia. So another one is monitor for tension, hemo, and pneumothorax. Updates. Another update. So instead of relying, this is the one for 9th edition. Once again, instead of relying with 2 or using 2 parameters of 80 to 90, we'll be focusing mainly on peripheral perfusion. Just palpate for peripheral pulse or radial pulse. In a non or uncontrollable hemorrhage, the fluid resuscitation now is perfusion-driven resuscitation, meaning we're no longer be basing on systolic blood pressure, but we will base mainly on peripheral perfusion. So if you can feel a radial pulse, then that's it. Doesn't matter what's the blood pressure, as long as you can feel a radial pulse, you're okay. But except for traumatic brain injury, okay? Tranexamic acid, this is indication for hemorrhagic shock. Any adult patient with hemorrhagic shock, at least 3 hours from the time of injury. So 1 gram over 10 minutes, okay? Additional 1 gram over 8 hours. These are just some of the advanced treatment in terms of hemorrhage. Tension pneumothorax. Let's move on. We call it a circulatory obstructive emergency, similar with hemothorax, open sucking chest wound, right? Once the air enters the mouth, automatic it will enter the mouth, goes to the trachea, and it will enter the lungs, right and left, to the right and left mainstem bronchus. But if there is some tension, there is some penetrating or blunt trauma that increases the thoracic pressure within the thoracic cavity. So what will happen? Look at the cursor. At least in open hemothorax, it will go out from that opening. But here, the air can enter. So once it enters the pleural space, it will compress the lungs. Okay, then it will lead to hypoxia. And the problem with tension pneumothorax, it cannot enter out. The air cannot enter out of the lungs. So it will remain inside the pleural space and therefore increase pressure, intrathoracic pressure. Okay, what are the signs and symptoms? Dyspnea, anxiety, tachypnea. Look at the chest, distended neck veins. Trachea. Trachea you can palpate for the tracheal deviation. You cannot inspect for it, but you can palpate. So, but rarely this is a late sign. So breath sounds diminish on the affected part, whether right or left, where the tension pneumothorax is, and it will create on percussion after your auscultation, when you do your percussion. Remember, any abnormalities in the auscultation, you need to percuss. So on percussion, you will hear a hyperresonance or hypertympany breath sounds. Okay? On hemothorax, what was the breath sounds on percussion? What was the result of percussion? We'll discuss it later. Shock with hypotension. Okay, this is the figure 22, pathophysiology and signs and symptoms of tension pneumothorax. So chest needle decompression, what is the life-saving intervention for tension pneumothorax? Decrease or absent breath sounds is not an indication for chest needle decompression. I say again, decrease or absent breath sounds is not an indication for chest needle decompressions for patients suffering from tension pneumothorax. So what do you need to do? You need to find for these three things, at least one, more than one of these symptoms or signs. There will be signs and symptoms: respiratory distress and cyanosis, loss of radial pulse, and decreasing level of consciousness. At least you have more than one of these signs and symptoms. So again, these are the following. These are the indications when to do chest needle decompressions. More than one of the following. Okay, respiratory distress and cyanosis, loss of radial pulse, decreasing level of consciousness. Breath sounds alone are not indicated for chest needle. Just to give you an idea, the anterior and the lateral approach. Okay, we all know about the anterior approach. It is the mid-clavicular line, second intercostal space just above the third rib, as you can see here. Then decompress with a needle long at least 5 centimeters in length, or 14 gauge needle. Then the axillary or the lateral approach, we call it the anterior axillary line, not mid-axillary. I say again, it's not mid-axillary, it's anterior mid-axillary line. Fourth intercostal space. Okay, these are the needle decompression site or landmark. Okay, let's define or differentiate tension pneumothorax and massive hemothorax. I took the liberty of emphasizing and highlighting the difference. Okay, the scene safety or level of consciousness, they may have the same. They may have a penetrating or blunt trauma. Level of consciousness for these two conditions, patient may both have decreased LOC. That's correct. Breathing, both will suffer or manifest rapid, shallow, and labored breathing. Same thing with massive hemothorax, rapid and shallow labored breathing. Pulses will be weak and thready, both tension and massive. Skin, both will suffer, both will manifest cool, pale, clammy skin as the patient is in shock. However, on neck, tension pneumothorax, the neck vein will be distended. Okay. In massive hemothorax, the neck veins will be flat. Breath sounds, both will be decreased or absent on the affected part. But look at the percussion. Once you percuss in tension pneumothorax, it will produce hyperresonance. And in massive hemothorax, dull on percussion. Okay, these are the two main differences in terms of tension pneumothorax and massive hemothorax. The rest are similar or the rest are the same. Let's move on. Next. The heart is surrounded by membranous sac called pericardium. Okay, so there's a pleural space. You can see the white one. We call it the pericardial sac. The heart is within the pericardial sac. So if the heart got injured, secondary to blunt or penetrating trauma, what will happen? It will bleed out. And blood or fluid will accumulate in the pericardium and prevents the heart from expanding fully. So it cannot adequately fill or pump blood. What do you call this one? Cardiac tamponade. Okay. What is cardiac tamponade? It's the rapid collection of blood between the heart and the pericardium from a cardiac injury. So what are the common signs and symptoms, or how do we diagnose cardiac tamponade at the scene? We have the hypotension, we have the narrow pulse pressure, and we have the Beck's triad. Beck's triad, neck vein will be distended, okay, or distended neck veins. Muffled heart sounds, but usually at the scene, it will be difficult to hear. But just in case you will hear it, it's one sign. The heart sounds will be muffled, and there will be hypotension, or in equivalent to pulsus paradoxus. What do you mean by pulsus paradoxus? So loss of peripheral pulse. So when the patient breathes in, you cannot palpate or you cannot feel a peripheral pulse. We also call it paradoxical pulse. So at this point, what will happen? The blood pressure will be decreased as well during inhalation. Therefore, decreased cardiac output, and will have, if the patient is hypotensive, there will be loss of peripheral pulse. So these are the following again, the Beck's triads: neck vein distension, muffled heart sounds, pulsus paradoxus as reflected by hypotension too. Okay. So what are the treatment or management for cardiac tamponade? It's a load and go. Can't do anything unless you are in the hospital, unless you are in the operating room. The definitive treatment for cardiac tamponade is surgery, but life-saving intervention is pericardiocentesis, which is usually being done at the hospital. So treat for shock, administer fluid, titrate to peripheral pulse, same again. Systolic blood pressure, having said the update, I will titrate to peripheral pulse for any uncontrollable bleeding. Then I will monitor and treat dysrhythmias and monitor and treat tension hemopneumothorax. Okay, so let's move on. That's pretty much about the presentation.
Grade number 1.
Okay, let's go back to the case scenario. Then we can open up the question and answer. On or about 8:15 in the evening, you responded to a 35-year-old male patient who sustained a single stab wound to the left anterior chest. Okay.
उधर का ही था एक
Mr.
Bed
Pravin,
number
can you, anyone who's kindly mute your microphone, please?
On the road,
Mr. Bhaskar, thank you. Level of consciousness, responding to verbal stimulus, awake but restless. The airway, the patient is shouting, please help me, my chest hurts. The breathing is rapid rate, poor air movement. The circulation is rapid and weak peripheral pulse, cool, pale, diaphoretic skin, and there is some bleeding from chest wound. Okay, I think I asked already, I pre-assigned the question. Mr. Arnel, what is your general impression and what is your priority transfer? How will you transfer this patient and what is your initial or general impression? Mr. Arnel, thank you.
Okay. So this is a case of a 35-year-old man who suffered a stab wound.
Oh, so is this a critical case or a priority patient?
Yeah, it's when your my initial impression is a priority case because it's a thoracic stab wound. We
Okay,
need
that's
to
good.
load into the victim after stabilizing his vital signs.
Thank you.
We need
That's
to
good.
load into this patient at
Yes.
assessment.
Thank you. Thank you. That's correct. What is the general impression of the patient and priority transfer? This patient is a load and go or scoop and run. This patient is a priority patient. We need to transfer him immediately. You should be putting that one at the back of your mind. Next one, Mr. Mike Nunez. What is your diagnosis based on your initial findings?
Okay, Jay,
You want to go? Let me go back to the initial diagnosis.
can you hear me? Can you hear me?
Yes, I can hear you. Thank you. Go ahead.
Okay, okay. My initial diagnosis for this one, since the level of consciousness of the patient is decreased and the patient is anxious and also there's a problem with the breathing as well as in the circulation, I believe that this patient is suffering from early sign of shock secondary to penetration trauma, and it can be a massive hemothorax.
Excellent. Thank you. That's correct. Thank you very much. With the knife on or without the knife on, I can make some scenario. Thank you, but thank you very much, Mr. Mike Nunez. That's correct. Based on the diagnosis, the patient's already suffering from signs and symptoms of shock, right? As evidenced by altered LOC, okay, breathing rate, rapid and poor air movement, circulation, cool, pale, clammy skin. This is a sign of shock. And there's also bleeding from chest wound. So, Mr. Boris, how would you further assess the patient?
I'll
Mr. Boris?
do a rapid trauma survey from head to toe.
Okay, so will you share some details about the rapid trauma survey, in particular with thoracic trauma, or in this case, what would you expect and what findings would you expect to see? Mr. Boris, you still there? That's correct. Rapid trauma survey. We will be doing a rapid trauma survey, right? It's a head-to-toe examination. That is correct. So in particular, we're going to be inspecting the mouth, the neck, and the chest. Okay, that's correct. We will perform a rapid trauma survey. It's a head-to-toe examination. What is the purpose of rapid trauma survey, which is part of the primary survey, is to identify life-threatening injuries and identify or provision of time-critical based interventions. That's the reason why we're doing a rapid trauma survey. Okay, then we'll take vital signs and sample history. Thank you, Boris. Thank you, Mr. Boris. So these are the details. Okay, the neck veins. During your inspection, you notice that the neck veins are flat. The trachea is still midline. Okay, there is a sucking chest wound. Perhaps you saw in the photo, it's the knife is still there, but we will assume that the knife has been removed. There is a sucking chest wound at the left side of the chest, though there's no paradoxical movement. However, there is a crepitus on palpation, no breath sounds on the left side, and there is a dull on percussion. The heart tones are difficult to hear because of the sucking chest wound, and the vital signs are the following. Blood pressure 80/60, pulse rate 130 to 135, less than 140, respiratory rate 36, SpO2 90% with high flow of oxygen. Next move is what are your treatment and management at the scene and en route to the hospital. Mr. Ronaldo, can you share your thoughts on this?
Scene, this facility is a loaded case. Patient showing signs of
Can you go nearby to your microphone, Mr. Ronaldo? Thank you.
it's a load and go case because the patient suffering from a massive pneumothorax
Mhm.
and shock. So within 10 minutes, you should be able to leave the scene. Okay.
That's
Make
correct.
sure that the patient's ABC is monitored and intact, airway is clear and open all the time. Because since you have a high respiratory rate, we need to assist with the ventilation because this respiratory rate is usually 36. So we can DBM the patient. DBM the patient.
Mhm. About
And
correct.
this SpO2 is a low. It's priority case.
Yes. In terms of
So
circulation,
circulation, you look for obvious bleeding. Check for the wounds.
there's a sucking chest wound as per the
Sucking
assessment.
chest wounds. As for the assessment, so you have to cover it with occlusive dressing.
So you don't have occlusive dressing as an update. What can we use in a practical approach?
If we have this Asherman chest seal, we can use it.
But if we don't have Asherman chest seal, what else?
We can use our hands.
Or the one that I just showed in the other.
AED pads.
AED pads. I'm sorry.
Yes, the DPIB pads. Yes.
Yeah, the DPIB
Thank you.
pads. Thank you.
So how about the
Then at
fluids?
the back of and at the back of the ambulance, we're gonna monitor the patient's LOC, ABC, and IV fluids, 2 large bore, just to maintain the peripheral pulse, to avoid the hemodilution and the bleeding of the patient.
Thank you. Thank you.
I'll do ECG of the patient. So,
Uh-huh.
because maybe patient suffered from chest injury, definitely he might suffer from heart injury also.
Thank you. Thank you.
Uh,
Yes.
I monitor for development of tension pneumothorax. That's
Correct. So is it possible to have some tension pneumothorax in this
yes,
case?
it's possible. Yes, it's possible. Especially he got an open chest wound, so
Mhm.
he might have a tension pneumothorax. He might suffer tension pneumothorax. Then just make sure that the receiving hospital is informed that you are arriving with the priority 1 case so that they are ready.
Okay.
Thank you.
Thank you. Thank you. Thank you, Mr. Ronaldo. Thank you very much. That was a very concise and very informative, detailed treatment and management that everybody or all EMS staff can perform. Whether you are in the ambulance, whether you are in offshore, those are the life-saving interventions and management that we can do. So high flow of oxygen, sealed chest wound, if it is an open pneumothorax, or if the wound is still there, stabilized impaled object, then we discuss about the fluid administration, maintain peripheral pulse, and immediate recognition and rapid transport. So the summary, chest injuries are time-critical conditions. They are often life-threatening scenarios or situation. They require an immediate recognition and prompt intervention. As we emphasize in our in the beginning, we frequently require a load and go, the old way of saying load and go, and we can also say scoop and run. And the airway oxygenation is always the priority. I will also add there circulation, as a treatment. So these are the references that we use, both the journals and those textbooks. And thank you for listening. So if you have some questions, you can reach me personally to my email ad. These are the telephone numbers. These are my email ad and my personal email ad. So thank you very much for listening. That concludes our presentation. I will stop my slides. So we'll open the question and answer portion. Thank you.
Thank you, Mr. Canaria. It is like comprehensive, and we give more information about how to manage the patient's thoracic trauma in the field. So we open up for our Q&A. You can raise your hands icon, and I will choose maybe more than one to whom want to speak first. Or otherwise, you can write in the chat box. Okay, while waiting, Mr. J, what do you think about the obstacle or challenges when you are treating the thoracic trauma in the field? And what are the cases most the challenging one as your experience here in Masai?
See, having said there are 12, we call it the deadly dozens, right? Those are the life-threatening injuries that you can experience at the scene. However, there are also those life-threatening injuries that you cannot immediately diagnose. That's why we focus on the first 6, because those first 6, most likely, if you are familiar with the signs and symptoms, right, even without the use of ECG, even without the use of ultrasounds, you can diagnose those like thoracic trauma. And then from there, you can provide those life-saving interventions, in particular, tension pneumothorax or needle chest decompression, close the sucking chest wound, stabilize the pleural chest. Now, I will say, to put some context, when I say stabilize, doesn't necessarily correlate to bulky vessel. Just cover, doesn't just cover, makes it to it will not further damage, then administer analgesia. I would love to incorporate or include analgesia in our setup. So same as well, I'm sure in the offshore, if you have this pleural chest, it's important for you to administer this medication. If you have access to morphine or fentanyl, that will be great. But for those who have a limited scope of practice, you can use your Pentrox and other pain medication. You can use paracetamol. I'm planning to include as well paracetamol drip in our setup, as in addition to our Pentrox. So those are some of the intervention.
Thank you for adding more information.
It's difficult to diagnose. The rest is difficult. All you can see there is the patient is deteriorating. Well, I guess I will see if you're suspecting any thoracic trauma. That's why we have some standard of staying how long at the scene, on scene time. Minimize it as much as you can. Load and go, transfer the patient, provide treatment at the back of the hospital. Remember, I presented a case or a literature that is a Qatar-based mortality as a correlation with prolonged on-scene time of the EMS staff. Thank you.
Thank you again for
question,
more
please feel
information.
free to ask question, gentlemen.
Yeah.
Ladies and
Anyone
gentlemen.
turn to us? We still have 20 minutes.
Yes,
Please.
that's why I allotted. I make
Question.
we have time.
Yeah, who is that, please?
Gozali from Dukan.
Mr. Gosari, go ahead.
Actually, my question already a little bit mentioned already by Mr. Chainal regarding the management of pleural chest. If I think in your slide before you mentioned it's not recommended anymore to applying the bulky dressing. My question is basically for me I'm agree, because with bulky dressing I think we can minimize the movement of the injured part. As you know, even in the case in pleural chest, there is friction of the bone fracture, so that causes the pain. Yes. I'm agree also the definitive treatment of the pleural chest, of course, with the painkiller. maybe we can use also for the Pentrox.
Yes.
But
yes.
for the stabilizing the chest, I think so far it's only bulky tracing that we can use this one. Maybe you have any idea how to stabilize the chest aside of bulky tracing?
No.
Thank you.
Salahuddin, Gusali, thank you very much. That's a very practical question. When I say bulky dressing, evidence says it doesn't help at all. But I did mention about stabilizing that flail chest. It's either you put dressing, then you administer analgesia. So bulky dressing in our practice, I would say, because we have some limitation in terms of opioid, right? Then that's why we will still stick with that dressing, but not necessarily bulky dressing. It's just something to cover and protect the flail chest from any further injury and administer pain relief. So pillows will be good. Same as well, recommended to stabilize the chest. See, one suggestion here, I can see flail chest, you can use pillows. Just cover it, put it there, administer IV fluid, administer analgesia or pain relief.
How about the use of the Pentrox? Because based on our experience, whenever we use the Pentrox, sometimes we will affected the level of consciousness of the patient. Maybe will. So what's your idea?
No, see, if you will ask me about Pentox, Pentox is a self-administered pain analgesia. If the patient cannot administer by himself because of altered LOC, then apparently you cannot give it. Correct. That's one indication. Second one, if you're not suspecting any head injury, and the patient, most likely, if it doesn't have any injury, the patient will be okay. The patient will have less altered LOC, then you can still give. So it's a case to case. I know there are some written definition or indication in the textbook, but having said, whether we will go clinically, if Pentox is a self-administered medication, if he can administer by himself, we will give it. But if he cannot, we don't do it by ourselves. So that's the indication for Pentox. And the challenge, Gusali, well, I guess the challenge for administration of Pentox is the patient, this is where the dressing will come in. The patient, its chest expansion will be limited, or he will limit his chest expansion because every time he breathes in, there will be chest pain, correct? There will be pain. So what we're gonna do there, right? Slowly, it's a challenging one, especially a practical approach. How would you administer Pentox to the patient? And encourage and be patient that he will do it by himself, and are hoping that the medication will take effect anytime, any soon. Okay, but in our setting, to just put some context in our setting, in particular in our QE EMS, the dressing will be still there. I'm just reflecting to you or presented to you the ITLS, the one that we're doing, especially for those advanced providers that have access to opioid, in particular morphine and fentanyl. But in our setting, you can still stick with the dressing and administer Pentox and paracetamol drip along the way. Thank you. That's all. Gusali, did I answer? Are you okay with that?
Yeah, thank you.
Okay.
Thank you for the answer. Anyone want to like to ask or confirm or share the idea or maybe experience while treating the thoracic trauma? You still have time, so this is the time. Whoever wants to share, please, or comments. Mr. J. Mr. Canaria.
No,
Yeah.
let us call someone. Yeah, I know you have questions, Sir
Yeah.
Aman.
Yeah, I just would like to confirm. Yeah.
Yes.
Thoracic trauma.
Perhaps
you
you can ask someone from our colleagues like Kafak, Mr. Mike,
maybe yes. Yeah.
Mr. Charles. I can see names here. Any questions is good. In here in our CPD setting, we want to create a learning environment. It's a safe environment. Everybody can ask questions. So please do so. Let us hear someone from Qatar Fertilizer or Kafak. Okay. Mr. Mike Santos, you have any question? Sir, your microphone is mute. Mr. Charles as well, hoping you will have a question. So I'll try to ask you afterwards, Mr. Charles. Mr. Mike, go ahead. Michael Santos, do you have questions, sir?
Nothing, Jay. It's okay, Jay.
Okay,
It's very
thank you.
informative.
Anyone else? Mr. Lewin, so I'm sorry, apology for putting you on the spotlight, but it's just something that I haven't seen you. I want to welcome you guys. Thank you for coming. So Mr. Lewin, any question related to thoracic trauma?
Hi Jay, no question. That was a really comprehensive discussion. Just I just want to what do they call based on also my experience on the receiving end of referral. Sometimes it's really helpful also to what do they call to describe the point of injury, especially when you have thoracic trauma. One of our concern would be a trauma to the thoracic box, which is part wherein most mediastinal structure are injured.
Yes.
So upon referral, it would also be great to hear what level, what ICS. Is it medial to the nipple or lateral to the nipple, not lateral to the nipple line? So those are the things that you should also include in our assessment when we are referring to the hospital.
Yes, exactly. Especially when you're doing remember, that's why we gave you need to be familiar. It is expected from us, right? As in my presentation in the beginning, in order for us to properly diagnose and identify those life-threatening injuries, we need to be familiar with basic anatomy and physiology. Remember, we, by healthcare providers, we are required to have high index of suspicion. That's our best tool at the scene. We don't have ultrasound. We don't have X-ray machine to confirm whether it's a massive hemothorax or cardiac tamponade. But knowing those basic signs and symptoms is our best tool when we are dealing with thoracic trauma. Thank you, Mr. Thank you for that question. Yeah, I totally agree with you. Remember that presentation? In the scenario, there is a left stab wound on the left side of the chest nipple line, whether it's somewhere in the medial. So what do you suspect? What organs will be affected? Possible injuries that the patient may occur. For example, in the diaphragm, we even need to know, sometimes if you are teaching this course, whom do you like to stab you? A female or a male? This is our the funny part. If you will be stabbed by someone, who do you want to stab you? A male or a female? It's the projection of the knife. Usually they will say female, they will stab like this, from up to down. The male will stab you from down to up. So it's a different penetration, different angle. So at the end, you need to be familiar with that. Even the type of ballistic bullets. Okay, whether it's a high or low force. Thank you. Anyone else? Mr. Charles, I already asked you. Good morning, sir. Welcome to our EMS CPD session. Do you have any question that you would like to ask? Anyone else? Because I want to see, I would like to welcome those you guys who just joined us. Uh, who else? Mr. Aman, go ahead with your question while waiting for somebody to ask questions. Go ahead.
Yeah, actually, yes. Since you mentioned about stab wounds, okay, you see that the patient is critical and load and go. So between the rapid trauma survey and focus, can we just, if it is sure that our assessment only just focus exam, and what do you think your idea about this, choosing between the rapid trauma survey and focus exam for any cases?
No, are you talking about multiple injuries or are you talking about an isolated stab wound?
Isolated stab wound.
So when do we do the rapid trauma survey then? Then we need to know the indication when to perform a rapid trauma survey or when to perform a focus exam.
Yeah, that's my questions.
Yeah,
So in
yeah,
this case,
yeah. I just answered indirectly. So question is, do we all need to do is spend time in doing a rapid trauma survey? If it is a not high significant mechanism of injury, not necessarily. For example, you're in a bar, when the patient was stab wound, you can focus on the affected organs. If you're talking about thoracic injury, focus on those organs or body parts. That's why I did elaborate in the discussion what are the body parts that you need to do the inspection, okay? Palpation, auscultation, and percussion. Check the head, you check the neck, you check the thorax. So those are the three major parts. Because in stab wound, I'm not saying it's wrong, but it depends upon when are you going to do it. You don't have to check whether there's a PMS on an isolated stab wound. So as rapid trauma survey and trauma assessment are applicable in all of the case, you just need to know when to use it. Okay, whether it's a focus exam or generalized rapid trauma survey. Thank you.
Thank you so much. Thank you for the answer. Anyone? I think we still have 10 minutes.
Yes.
Or maybe 8 minutes exact.
I can see faces here. Joel.
Please.
Welcome, Joel. I haven't heard you for a while, Joel. Joel Castro from Ducan. I want to hear. Hi, Joe. Good morning. Do you have any question?
Good morning.
Any question or any inputs that you want to add? So everybody will learn.
I think Mr. Dodi want to ask.
Mr. Dodi, go ahead, Mr. Dodi.
Yes, Mr. Jai.
Yes, hello, Mr. Dodi.
In real case, we have some tension pneumothorax.
Good.
In our guideline,
let everybody hear it because this is a real scenario. Thank you. Thank you for sharing.
yeah,
Please share it, Mr. Dodi.
Did we allow to do the chest decompression in our protocol?
In the patient care guidelines, those who have been trained to do needle decompression are the only one because we have existing patient care guidelines. And the one who are allowed to do it are those who are the paramedics are the one. So if you want my answer, if you want my direct answer to that in relation to our patient care guidelines.
So only paramedic.
Yes.
Yeah. How about if we ask on-call doctor and then he said this up to you?
See, it boils down about the credentialing and the levels of training that you have. See, this is the dilemma that we are facing right now. I did mention it to you last time. How many of you did I ask? I asked question last time. How many of you, when was the last time you attended an advanced cardiac life support and an advanced trauma life support courses, which somehow required in your scope of practice as an EMS staff? So from a medical perspective, medical direction point of view, okay, how would I ensure, what is my assurance that the EMS staff can perform it well? It boils down again with the credentialing, it boils down again with the certification and levels of training. So that's how I answer you to put some context formal context on it and formal answer on that one, Mr. Dodi.
Yeah, it's difficult. Sometimes my friend told me, lipid patient cardiac arrest, don't do chest decompression.
We're talking about cardiac arrest now. What do you mean? Sorry, please,
No,
can you?
what I mean, when we have the sign of tension pneumothorax, we are not doing chest compression. But
Yes.
actually, this is critical that treatment we should do chest decompression. You know?
Okay, another one. Let me just, I know, I understand. That's why it's our dilemma, because it's our dilemma right now as an EMS service to meet the required levels of skills and knowledge in relation with our patient care guidelines. Why? Let me put an example on this. When was the last time, for example, in cardiac arrest? What are the cardiac arrest medications that you can give? Epinephrine. Anyway, we're going away from trauma, but in your scope of practice, the last certification that they have, what is the medication allowed in your certification? Are you allowed, for example, to give atropine? Are you allowed to give amiodarone, yes, for cardiac arrest, and epinephrine for cardiac arrest? Any advanced cardiac medication? Do you have training for that?
Yes.
Right. So that's why. No, I'm talking about. I'm not talking about individual one. Right, because our patient care guidelines are within the ACLS level, wherein so you will give some atropine, you will give some forms of level of medication. The question is your level of training, your certification, are you allowed? So, but this is the good news, because I have conceptualized this one, strategic planning. I have put it in strategic planning. If the company cannot provide the level of training required for our patient care guidelines, then we will do an in-house certification. You understand me? We will provide an in-house certification. How do we do that? We will provide training that covers the scope of practice required in the patient care guidelines.
Okay, good.
So that's the goal. That's our goal for next year, Dodi. Just to give you
Okay.
some idea. If they cannot provide, our department cannot provide, our company cannot provide an ACLS course, perhaps one of the sessions of the plans next year is to discuss, or a CPD session related to advanced cardiac life support medications. Then from there, it's a form of credentialing, right? And knowledge and skills related to the required scope of practice that you have. Otherwise, it cannot. So we need to find ways on how to do that.
Okay, good. But I want to ask about your what is the last question. There is three sign that we will do chest decompression in when there is a sign of symptom. Only three requirement. One is absent radial pulse.
Correct.
And then second one is altered mental status.
Yes.
And then difficulty in breathing. What do you think?
Not difficulty of breathing, cyanosis and respiratory distress.
Yeah.
So difficulty of breathing is different. Cyanosis and respiratory distress and failure are the keywords. Not
Yes,
DOD.
yes. Mention three.
One out
How
of three.
only two?
More.
Only two?
I think I've mentioned there, you should have more than one.
Yeah.
So if you have two, then it's
two,
good.
you can.
I told you, if we have more than one, then you
Yes.
can do a chest needle decompression. So if you
Okay.
have two, then I'm not saying it's better. So, but the requirements are there.
Yeah. I mean, even two, we can do it.
More than one, yes, two. Correct. Two.
Okay. Yes, that is my question.
Two. At least more than one. That's two. Okay, that's correct.
What I mean is, sometimes when we are checking in,
I'll tell you, Dodi.
Radial pulse, sometimes it's difficult, you know.
Dodi,
So
Dodi,
at
I'll
least
tell
two.
you. Most likely, this is a common question being thrown to me for the last, since 2007, when I started teaching ITLS course as an ITLS instructor since 2007. most likely those patients who are suffering from tension pneumothorax in a severe state, automatically they will have shortness of breath or respiratory cyanosis, right?
Yes.
They will have altered LOC because they are in shock. And therefore, if they are in shock, they will have decreased loss of radial or peripheral pulse. So in a severe case of tension pneumothorax, automatic those all of those symptoms, signs and symptoms will be present. Okay.